So thank you all for joining today's webinar. We are very excited that you have taken the time to be with us at the Ohio AAP and our team for this education. So I will get us started. My name is Haley Southworth with the Ohio AAP. I'm here on behalf of our team. This training is hosted by the Ohio Chapter American Academy of Pediatrics under our Parenting at Mealtime and Playtime program. In its 22nd year of funding, PMP has provided evidence-based education to physicians, nurses, home visitors, community health workers, and more. The Ohio AAP is excited to continue this work of PMP and looks forward to diversifying its audience and topics. If you have any ideas for the program throughout today's session, please share your ideas in the chat, or you can reach out to Suhavi, our PMP program manager. We always appreciate learner feedback. And the slides from today's session will be sent in a follow-up email. I'm going to start with just a few housekeeping items. Please do keep your camera and audio off during the session. You are welcome to use the chat feature for questions. On the next slide, I would like to just extend a thank you to our funder. And yeah, perfect. The Ohio Department of Health has funded this education, and we appreciate them for supporting the health and wellness of children in Ohio and the PMP program. Next slide, please. The speakers, planners, and others in charge of this education have no relevant financial relationships within eligible companies. Also, we have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is our intent to foster respect, belonging, support, and accountability with regard to the patients we serve. If you have any concerns or questions or comments, please contact Kelsey Logan at the email you can see on your screen. And then on the next slide, I wanted to share the objectives, which you can see here. We will also send an email for CME and other pieces that will be related to claiming the credit, but these are the objectives for today's training: to describe the relationship between food insecurity and disordered eating behaviors in children and adolescents, identify early signs of disordered eating that may emerge in food insecure households, and differentiate between adaptive survival behaviors and concerning patterns. Apply a trauma-informed approach when discussing eating behaviors with families. Encourage collaboration among pediatricians, caregivers, and the healthcare team to optimize outcomes. And next slide, please. I would like to give an introduction, and then I'm going to turn it over to our two speakers for today. Today's training is being hosted by Erin Talzia and Danielle Brooks. Erin Talzia is a pediatric dietitian specializing in community food supports, including nutrition education classes, healthy cooking classes, and food insecurity programming. She holds a master's and bachelor's degree in dietetics and has been a practicing dietitian for 10 years. Erin has been in practicing in the clinical realm for 6 years and the community realm for 3 years. As the Community Food Equity Manager at Dayton Children's Hospital, Erin currently manages a community teaching kitchen, food pantry, emergency food bag program, and produce delivery program. Danielle Brooks is a registered dietitian licensed in the state of Ohio. Danielle holds a certification of advanced practice in clinical nutrition and is also a certified diabetes care and education specialist. Danielle provides compassionate and empathetic nutritional care to adolescents and teens with eating disorders on an outpatient basis, as well as all ages of pediatrics with type 1 or type 2 diabetes at Dayton Children's Hospital. And with that, I'm going to turn it over to our team. Thank you so much for joining today, and let you kick it off for us.
Thank you very much. Today, we're going to discuss the relationship between food insecurity and disordered eating in children and adolescents. This topic is at an intersection of pediatrics, behavioral health, nutrition, and social determinants of health. In pediatric practice, we encounter eating behaviors of concern at times, and it can be a challenge to determine what is contributing to these behaviors and what they mean. We may think to ourselves, does this family need more education? Are we seeing an eating disorder? Is this an adaptive response to something such as food scarcity, or is this something that lies somewhere in between? Misinterpreting survival strategies as pathology can unintentionally stigmatize families and lead to inappropriate and ineffective interventions. Alternatively, missing early signs of clinically significant eating disorders can delay necessary treatment. So, today we want to build awareness and some nuances surrounding these topics and to help us identify and differentiate on how to respond in ways that are clinically sound, compassionate, and trauma informed. Let's begin with why this topic matters in pediatric care. We continue to see increasing concerns for disordered eating behaviors in children and adolescents. 1 in 5 children may show signs of disordered eating. 30% of girls and 17% of boys experience disordered eating in adolescence. We know childhood and adolescence are critical periods of growth and development, and body weight and growth may be affected by changes in eating habits. Primary care providers are positioned to be one of the first to notice changes in growth trajectories concerning eating patterns and emotional distress surrounding food. And caregivers may not be aware of signs of eating disorders or that their children are struggling with food and may not identify growth changes as being problematic. Food insecurity remains common in the United States and affects millions of children each year. Compared to individuals with adequate food access, individuals experiencing food insecurity are 3 to 5 times more likely to also experience an eating disorder. Strikingly, this association remains present even when controlling for relevant socio-demographic factors. And this highlights the strong relationship between food insecurity and eating disorders. Complexities in assessment arise because food insecurity can produce behaviors that look similar to eating disorders. So, as pediatric providers, we're uniquely positioned to identify these patterns early, ask the right questions, and reduce stigma through thoughtful assessment.
So to start with this in-depth topic, we're going to talk about some terms before we get into the research. So the first thing we're going to talk about is food insecurity. So of course, most healthcare providers know what food insecurity is. It's usually thought of as the hunger or not being able to satisfy hunger with enough food. However, it is a little bit more complex than that. When we think of the flip side, those who have food security, we think of them as having enough food to live an active and healthy life. So therefore, those who have food security are able to access food that they themselves, their family, society deems as healthy. So a family who might be able to afford enough food or access enough food for enough calories for their family may not actually meet that definition of food security, where they don't have the access of variety to foods, they don't have foods from every food group, especially quality protein and fresh produce sources. So they don't truly have food security, even if they're able to afford and access enough food from a calorie perspective for their families. In 2016, the technical term of food insecurity was changed by the USDA's Economic Research Service to change it to different levels or increments and severities of food security. So you can see that there's 4 outlined on this slide here. And one would argue that our second one, the marginal food security category, would be still deemed as food insecure. However, USDA's Economic Research Service does categorize marginal food security as food secure. However, as a dietitian, and I'm sure as all of you as healthcare providers, we would really love for our families to have the top realm, which is, having access by all people in the house at all times to enough food for an active, healthy life. With the marginal food security, if there's any kind of anxiety over being able to access enough food and calories and nutrition for their family, that I still feel like is part of the whole psychological damage that food insecurity can have for a family. So I really advocate and desire for everyone to have that top categorization. Really, any anxiety over having sufficiency of food and adequate nutrition is a failure on our part of society and can really cause that psychological harm to families. So then we're going to look at the prevalence of pediatric food insecurity in the US. So this demographic, or this, sorry, graphic here, you can see this is the US households that contain children. So this is not a survey of all US households. This is specifically US households with children. So 81% of those households that have children are food secure. The other about 18% of families who have children are food insecure. So they would be prescribed as the low or very low food security that we saw in that previous slide. So about half of those families that contain children in the households that are food insecure are only have food insecure adults, whereas the children themselves in those houses are food secure. And that's because many parents will shield their children from their food insecurity, and they will deprive themselves of enough to eat or enough nutrients to make sure the children in the household have enough food to eat, enough nutrients. So then we have the other half where the family, the whole family, so the parents and the children are experiencing that lack of access and consistency of nutrients in food. These numbers, the percent numbers, translate to about 3.3 million households that are food insecure. And then that means that about 7.3 million children in the US are food insecure. So that's really a staggering number for our well-developed, wealthy nation. And you can see that this is data from 2024, and that's because it takes us a long time to analyze and interpret and then report out the data that we collect as a country. And so the 2024 data was not reported until the fall of 2025. So that's why we're looking at 2024 data here. So when we think of those 7.3 million children without consistent access to food, we actually know that they fall in every single county in the US. So even those wealthier counties still have children who have food insecurity in those counties. Some nice, helpful way of figuring out, if your own county has a fair amount of food insecurity is using this Feeding America's Map the Meal Gap. So I don't know how many of you are actually familiar with this tool, but it's a really great tool to use to kind of figure out where you live, what kind of food insecurity children have in your area. So this map is kind of still loading, but you can see that we have this demographic tool here. So you can click on what kind of demographic we're looking at. So we're going to focus on pediatrics, so child here. So then it'll kind of change, and then we can scroll down and see the data below. This is the 2023 data of the United States. So if you want to see your county, you're going to click on your state, and we'll see if this will load for me here. So I'm clicking on Ohio because that's where I currently reside. And then you can see it's still child, and you can scroll down and see the information for Ohio. So there's a child food insecurity rate of 20.1% in Ohio. And then I'm going to click actually on Montgomery County, which is the county that I currently reside in. And so we'll go down and we'll see that there's even an increase in Montgomery County, 24.3% compared to Ohio, of child food insecurity. So also what interesting data over here on this side is that 1/4 of those kids who experience food insecurity do not qualify for federal nutrition programs. So that means SNAP or food stamps, and also those free and reduced price lunches at school. And then the other 3/4 do qualify for those programs, so SNAP and the reduced and free meals at school. So that means that even when families have access to SNAP and free and reduced price lunches, they still experience food insecurity. So a lot of times families don't have enough from those supports and from maybe what they're making or the money that they're able to get to support their families with the need of eating and having access to all of those foods that they need. And then we have 1/4 who don't qualify because they make that much more money than what would qualify them for those programs. So they still need to find ways to have enough food for their family. So they use a lot of the local food pantries, churches, and soup kitchens. So we can kind of see that, there's different categories of people who experience food insecurity and why they might fall into food insecurity. So we're going to switch back to our presentation. So I just wanted to review that we know that now that really food insecurity is not rare, and it disproportionately impacts those facing systemic inequities. So those who experience poverty, structural racism, housing instability, they also typically experience food insecurity. Now, food insecurity has two parts. It's the ability to afford those foods, but it's also the access piece. So you might have enough money to afford, but if you don't live near enough to a grocery store that provides those variety of foods, fresh produce, quality meat, protein sources, then you could still be deemed food insecure. If you don't have that transportation to get to those grocery stores that do provide those, or the walkability of your city, then you would still have a food access problem. So there's more than just the being able to afford the food piece to that as well. We know, though, then those people who maybe can't afford produce and high quality protein sources and all the different food groups and variety typically end up choosing and being able to afford foods that are highly palatable, energy dense, but low in nutrition. And we know over time, intake of this food chronically can lead to a lot of different mental and physical health disorders. So it's not surprising that that can really play into disordered eating or eating disorders.
The National Eating Disorder Association describes disordered eating as a spectrum of problematic eating behaviors, distorted attitudes towards food, weight, shape, and appearance. Disordered eating patterns vary in severity, but do not meet the frequency, duration, and psychological criteria for a diagnosable eating disorder sometimes. Specific diagnostic criteria for each of the major eating disorders is outlined in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5, including anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, and other specified feeding and eating disorders. Often, these disordered eating or eating disorder behaviors may include dieting, skipping meals, fasting, restricting food intake, eliminating specific foods or food groups, binge eating, excessive use of laxatives or use of diuretics, weight loss medications, as well as compensatory behaviors such as purging or excessive exercising. Both disordered eating and eating disorders can cause distress and impairment in our daily functioning. A number of biologic, psychological, environmental, and sociocultural factors are known to contribute to the development of eating disorders. Some biologic factors include a family history of eating disorders, history of dieting, type 1 diabetes, and genetic predisposition. Some psychological factors that may contribute to eating disorders include perfectionism, body image dissatisfaction, and mental health conditions. Many social factors can contribute to eating disorders, including weight stigma, bullying, trauma, and cultural values. Environmental factors such as family, friends, school activities also can play a role in the development of eating disorders. Adapted behaviors are learned behaviors that reflect an individual's social and practical competence to meet the demands of everyday living. As environments change, individuals must learn new skills in order to meet environmental demands. Influences and adaptations in regards to food environments may include the timing and frequency of meals and snacks consumed, the eating environment, flavor and texture preferences, preparation methods used, individual cooking skills, variety of foods eaten, shopping strategies, and modeling of behaviors, eating behaviors by family and peers. Some examples of adaptations specifically for food insecurity may include buying cheaper food, increased consumption of grains and starches, and reduced consumption of protein, fruits, and vegetables, batch cooking, relying on food assistance programs to cope with hunger, eating less frequently or less variety in food intakes, and more.
So next we are going to move into the research. So we know that those who are affected by food insecurity may engage in eating disorder behaviors for reasons that don't fit the typical mold of eating disorder pathology that's typically targeted in preventative diagnostic and treatment practices. And this makes sense because chronic uncertainty about food access creates this ongoing stress in the family and in the child, which influences both psychological coping and physiological regulation in children. There are substantially fewer studies that examine the association between food insecurity and disordered eating among adolescents and children compared to studies that are available comparing adults. But we do know that food insecurity is positively associated with disordered eating in youth. And those associations vary by type of eating disorder, also different severities of that food insecurity that we talked about at the beginning. We do know from research for both children and adults that food insecurity is linked to an increased risk of binge eating, hypervigilance around food, emotional and stress related eating, weight cycling, and growth faltering. So, we are going to outline that research here in the next couple of slides. So first we'll talk about food insecurity and growth. So this isn't specifically disordered eating, but we know that that's a huge component for children is growth, and that's what we're looking at as healthcare providers. So there was an excellent 2024 meta review that examined the influence of food insecurity on children and adolescents and evaluated if the relationship was just causal or just associative. It reviewed a lot of different articles out there, so research articles, systematic reviews, meta-analyses, coping reviews, and more. They used the NIH Quality Assessment of Systematic Reviews and Meta-Analyses tool to see if these studies were of quality. They identified some different themes when it came to food insecurity. They identified growth status, dietary intake, anemia, health and illness, academic performance, mental health and behavior, and psychological development. They had many different findings that we won't go all into today, but they did find that in regards to growth, food insecurity was linked to a higher stunting risk with a higher severity of food insecurity, but it also existed with any type and any severity of food insecurity. They also found that the household food insecurity was linked to a poor dietary intake and nutritional status, which we can typically think of when we think of food insecurity regardless. They also found that those with food insecurity were more likely to be hospitalized, have asthma, malaria, respiratory diseases, anemia, poor oral health, higher infant mortality, higher levels of cortisol, increased behavior problems, and mental health issues. So there was a lot of different findings and themes they found in the research and the literature. Now, when we specifically look at the US, and so we're mostly all US based, is that we find that there is a little bit differences with growth and food insecurity than maybe seen in our sub-African and Indonesia and some other studies that were done in some other countries. We find that there's maybe a higher BMI, so maybe not growth stunting or as much in the US with food insecurity. So that does correlate a lot with what we've talked about already, where when people face food insecurity, they're more likely to choose and to be able to access palatable, high calorie dense foods, but not high nutrient dense foods. So along those lines, they found that there was a higher intake of added sugar among children who were 6 to 11. There was a lower fruit and vegetable intake among children 1 to 5. So we can see that those themes kind of play out when we think of BMI and growth and food insecurity. This meta review did highlight that there is a much larger need for longitudinal studies so that they can kind of account for the confounding factors and more qualitative studies to really figure out what kind of children's experiences with food insecurity, how they feel, and what their consequences are when it comes to like more qualitative data for the children. Now, we also know that we just talked about how food insecurity affects nutritional intake and therefore what could cause nutritional deficiencies. So when we look at food insecurity, we primarily see that nutrition is affected through iron intake, calcium intake, magnesium, vitamins A, D, and E. So those are the main kind of assessed nutrients that we've seen are become deficient in a food insecure population. These nutrients do play a significant role in the body. They affect neurodevelopment, immune status, hormone production, and these hormones that are affected provide a lot of different pathways in the body, but we know that they also influence hunger and satiety and fullness cues. So that's a pretty obvious link then to the lack of consistent, adequate intake affecting how the body understands hunger and fullness, and therefore maybe how they start choosing behaviors to adapt to those changes in their body. We also know that these hormones are chemical signals and cognitive processes, mood, gut brain connection with the vagus nerve. And this all affects digestion and the composition of that gut microbiota. So, those alone also show us a link to that influence of contributing to eating disorders, or which are mental health disorders, which are highly influenced by the lack of hormones or the too much hormones with the neurotransmitter and chemical processes. So we can see another link between not having all of those awesome nutrients and how that could develop in a mental health disorder, specifically an eating disorder.
This slide lists a few studies on the relationship between food insecurity and eating disorders. The first one is a systematic review that was conducted in 2023 investigating the relationship between food insecurity and eating disorders in children and adolescents 18 years and younger. And the study found a positive association between binge eating, loss of control eating, eating in the absence of hunger, and unhealthy weight control behaviors, as well as picky eating with varying severities of food insecurity. The next two studies had similar findings of increased binge eating or extreme weight control behaviors and binge eating. The last study on the slide was a 10-year longitudinal cross-sectional cohort study that found higher eating disorder behaviors and prevalence of binge eating disorder even 5 years after extreme food insecurity. So this research shows increased risk of eating disorders in general when food insecurity is present, and specifically more so with the more extreme food insecurity. We can see increased weight control measures, notable higher prevalence of binge eating with or without compensatory behaviors. One theory for this is referred to as the feast or famine cycle, where food intake increases during periods of food abundance and decreases when food becomes scarce once again. Inconsistency in the availability and consumption of food, regardless of the reason for food restriction, whether it's due to a desire for weight loss or maintenance or due to food scarcity, is thought to trigger feelings of deprivation, predict preoccupation or hypervigilance with food, and increase vulnerability to subsequent binge eating. Research also suggests that the experience of insufficient resources itself can create a scarcity mindset, increasing attention towards the scarce resource itself. Individuals may often still feel that like resources are scarce even in times of abundance. These individuals often experience this hypervigilance or tunnel vision, thinking about food or the lack of food. And as mentioned, this even persists in times where food is plenty, we see. We know that when food becomes available, perhaps after a paycheck arrives or visiting a food pantry, children may overeat, and when food becomes scarce, intake may decrease. Over time, this cyclical pattern can disrupt hunger and satiety cues. Research has found that food insecurity has been associated with poorer self-regulation and self-control. There's an association with higher incidences of aggressive behaviors in children, as well as an association of internalizing negative emotions has been found with higher food insecurity. Both perceived and actual food scarcity are thought to affect people's cognition, choices, and behavior. Individuals are devoting excessive attention to scarcity related issues, leading to an increased cognitive load, which results in less bandwidth or mental capacity to focus on other things and negatively affects their executive function and impacts their daily life. Research suggests that these individuals may behave irrationally, such as with inattentiveness, impulsivity, memory loss, and irrational decision making. Having autonomy and agency to choose foods to purchase and consume is associated with greater food satisfaction and eating behavior regulation. Experiencing food insecurity makes it difficult to have autonomy in food choices, given limited access to sufficient quantity and variety of foods at times, and potential limitations on the types of foods that can be purchased with some of the federal assistance benefits. This lack of autonomy may be a contributor to feelings of deprivation that can lead to binge eating among individuals experiencing scarcity. Many individuals report feeling ashamed of their financial limitations, and shame about finances and food access may also translate toward attitudes towards eating. As Erin mentioned earlier, many parents strive to protect their children as much as possible from hunger and nutritional deprivation. So some studies have shown that households experiencing low dietary quality affects adults more than the household's children's, as the parents strategically will limit their own intake in effort to spare their children. This is a good reminder to avoid blame and judgment when working with these families. Environmental realities in low-income neighborhoods include decreased presence of full-service grocery stores, increased availability of fast food restaurants, and energy-dense, nutrient-poor food, and this may create barriers for low-income families trying to adopt healthy behaviors. Inconsistency with food availability can lead to unhealthy eating patterns and increased stress that may make weight control difficult and facilitate to the development of obesity. This may lead food-secure individuals with a desire to lose or maintain their weight to turn to alternative and potentially harmful weight control strategies, such as skipping meals or self-induced vomiting. Children and adolescents may experience competitions for food when there is adequate supply. Siblings may fight over foods. This could potentially lead to binging, hiding or hoarding foods in rooms or bags or other places in effort to ensure it will be available to them later. And alternatively, some older siblings may give food to their younger siblings, sacrificing their own intakes. Energy-dense food may also be used to compensate for times when food is scarce. And as I mentioned, and Erin mentioned, psychologically, children may develop heightened anxiety around food availability. Food insecurity is a stressful life experience for a household, and evidence shows positive relationships with perceived stress. When a child doesn't know whether food will be available tomorrow or whether there'll be enough for everyone at the table, the body's stress response system activates. This cyclical pattern affects their appetite regulation hormones and stress responses. And when that activation is happening repeatedly, it influences emotional regulation and appetite regulation. Emotional eating can develop as a coping strategy in the context of chronic stress. Physiologically, appetite regulation hormones such as leptin and ghrelin are influenced by this inconsistent intake. We also see that food refusal and picky eating may be greater with food insecure households. One study examined the relationship between food insecurity and picky eating, and food refusal was greater for youth who have food secure households when parents were stressed or depressed, but it was greater for youth with food insecurity regardless of the parents' moods. One might expect youth with food insecurity to be more willing to eat a variety of food considering scarcity. However, in food insecure households, less ability to purchase preferred items may potentially lead to more food refusal if children are disinterested in the available options. These children may also have less exposure and experience with variety in food items. And in some households trying to make food stretch, food may be used longer than what the recommended shelf life is. In practice, I've seen fear and distrust of foods were not prepackaged and shelf stable due to a history of trauma surrounding limited availability of food outside spoiled foods in the house. I've also seen food refusal and picky eating due to a lack of exposure to variety of food. Many studies surrounding these topics are self-report and surveys, so it's also important to consider that some parents with food insecurity may perceive their children to be pickier eaters when exposure and availability are playing a role as well. In general, research has shown that boredom is associated with greater energy intake, as well as the consumption of higher quantities of fats, carbs, protein, and energy-dense foods. But emotional eating and eating out of boredom may not be as prevalent in these food insecure households. This may be given to the fact that food may not be readily accessible during moments of negative affect, emotions, or boredom in these households, and so youth may be more apt to use alternative methods of coping to alleviate their psychological distress.
So we've already talked a lot about how parents cope with food insecurity. So you can see that there is some evidence-based listing on this slide of some things that they do in order to kind of combat that food insecurity. We also know from a lot of different research and from our experience working with kids and families that when parents model something, children will do that as well, even if they don't specifically say to do it. So, especially with picky eating, when parents eat a variety of foods, kids are more likely to eat a variety of foods. So, it makes sense that if a parent is doing some kind of behavior due to food insecurity, that the child in the house would likely do those behaviors too. We do have research that shows that mothers who experience food insecurity will do some kind of adaptive behaviors such as binging, and their adolescents are more likely to also experience binging. We know that families who experience food insecurity also have a lot of other stressors and usually experience poverty, low parental education, maybe single parent households. And we can see that a lot of times they're stressed to the max and usually don't have those other family assets, such as the safe and supportive environment that kids need in order to thrive. So given that, we know that there's a lot of different parenting, behaviors that would influence how the children would then express themselves in regards to food. We see that this can also translate to the classroom, so teachers and schools and other caregivers do influence children's behaviors around food as well. We have data that shows that adolescents who experience food insecurity are more likely to consume fast food, eat fewer fruits and vegetables, higher sugar beverages. They're less likely to experience family mealtime. And so it makes sense that we see some of these behaviors become apparent in children as well. So we've kind of already stressed a lot of this, so I'm going to move on to our next topic. So we were going to highlight the adaptive survival behaviors and what are concerning for clinical eating disorders and maybe those that aren't actually clinical eating disorders. So when we think of eating disorders or disordered eating coping behaviors, we need to think about the intent or the underlying driver behind the behavior to help differentiate whether it's a coping mechanism or it's actually a clinical eating disorder. So food insecurity driven behaviors are typically resource triggered. So they can improve when food access stabilizes. We do know from some research it takes a really long time for that to come about because we see that 5 years later people can still have their kind of adaptive behaviors in play, especially if they experience very severe food insecurity. But we can kind of tease out those different behaviors when we talk to the child or the family. Where clinical eating disorders are concerned, those are very much driven by body image concerns, rigid beliefs about food and health and wellness, control needs. They need to control something, so they decide to control their food. and they're persistent regardless of access. So they're not going to improve when they have an abundance of food in front of them. They also have distress and impairment in their life, can be a kind of a trigger or a like make you think, oh, this is a clinical eating disorder. Because when we present someone with a clinical eating disorder with food and encourage them to eat it, they will react and have higher distress than someone who, it doesn't have that access to food. And wow, now that food's in front of them, they're going to want to eat it and won't be so distressed. So that kind of can be another way of teasing that out. So the common adaptive behaviors that also are eating disorder behaviors are hoarding or hiding foods, eating really quickly, overeating when food's available, skipping meals, and picky eating. So it's kind of it makes sense. It's obvious that these behaviors serve as a protective function when there's unpredictability. So it's hard to not do these behaviors when you don't know if food's going to be available for you or not. However, these are also kind of behaviors that those who have clinical eating disorders also may do in order to kind of get to their get into their mental health disorder.
So some red flags for clinical eating disorders may include, as Erin mentioned, intense distress or rigidity surrounding food, rigid food rules regarding what, when, and where specific foods will be eaten, preoccupation with weight, weight loss, calories, dieting, refusing certain foods, potentially eliminating entire food groups, avoiding meal times and situations involving food, particularly social situations involving food, rituals such as eating food in specific orders or excessive chewing, eating less, always leaving just a little bit on the plate, or eating large amounts of food in a short period of time, and routine bathroom use or showering after eating. We may see marked weight changes or growth trajectory deviations. We may see withdrawal from friends and pleasurable activities, secrecy that's unrelated to scarcity, and distorted body image, and extreme focus on body size and shape and body checking. Behaviors specific to binge eating would be engaging in eating large amounts of food in a quick period of time, typically, often maybe accompanied by restricting for long periods of time afterward and kind of going on this binge restrict cycle. Feelings of lack of control over the ability to stop eating is common with binge eating. Shame, guilt, despair, stealing or hoarding foods in strange places, and creating schedules or lifestyles to make time for binge sessions may occur. If bulimia nervosa is present, binge eating is often accompanied by the compensatory strategies of self-induced vomiting, potential diuretic or laxative use, fasting or restricting, excessive exercise, and manipulation of insulin doses if a patient has type 1 diabetes. These patients may drink excessive amounts of non-caloric beverages at times prior or during binges prior to purging. You may see cuts and calluses across finger joints from self-induced vomiting. They also may have more dental issues due to erosion of tooth enamel from purging, periodontal disease, cavities, temperature sensitivity, and we may see enlarged parotid or submandibular glands at times. Objective growth data may help to differentiate between adaptive fluctuations and clinically concerning restriction or binge patterns. If these changes, if this growth data persists even when food access is stable, then that could be more of a sign to evaluate for an eating disorder. Early diagnosis and treatment are associated with higher rates of recovery, and extended illness is associated with potentially devastating consequences in an eating disorder population. Food insecurity is associated with a higher prevalence of mental health problems, making early and routine screening an important preventative healthcare measure. Mental health screening is also important for individuals with eating disorders. Eating disorders have the highest mortality rates of any mental illness, often co-occurring with depression, anxiety, trauma, and suicide risk. Early detection through screening improves recovery rates, addresses hidden complex psychological factors, and allows for earlier intervention. Individuals with eating disorders may not look emaciated, so screenings can help identify cases where medical damage is occurring regardless of the actual body weight. Standardized screenings can be used to provide a uniform approach to identify health conditions, risks, socioeconomic needs, and allow for timely interventions and improve patient outcomes. Universal screenings also reduce stigma and normalize conversations. Using validated screening tools, they're brief, evidence-based, reliable, and accurate, and can be integrated into routine visits with patients. Growing evidence shows that if we deal with unmet health-related social needs like homelessness, hunger, and exposure to violence, we can help undo their harm to health. Just like clinical assessment tools, providers can use the results from these screenings, such as the health-related needs screening tool, to inform patients' treatment plans and make referrals to community services. The Hunger Vital Sign is a screening tool that identifies households as being at risk for food insecurity. In October 2015, the American Academy of Pediatrics released a statement recommending that pediatricians screen all children for food insecurity. We've also listed on the slide a few screening tools for eating disorders that we've seen used in pediatric practices. The SCOFF is a brief 5-question screening test. The Eat 26 or Eating Attitudes test is a self-report screening tool that has 26 attitudinal items and 5 behavioral frequency questions to help identify eating disorder risk. And the Eating Disorder Examination Questionnaire is a 28-item self-report questionnaire that is used to assess the range, frequency, and severity of behaviors associated with eating disorders. Growth chart monitoring is also essential for food insecure children, as well as children and adolescents with eating disorders, as it provides objective data and can be an early warning system to detect deviations from established growth trends. It allows for timely interventions such as nutrition counseling or referrals to assistance programs. Mental health screening is also vital for food insecure children to identify and mitigate risks of anxiety, depression, behavioral issues, toxic stress, which can cause permanent development changes. This slide is a case example. A 10-year-old patient is hoarding snacks in their bedroom and eating rapidly at school lunch. The family recently experienced job loss. Is this adaptive or eating disorder concerning behavior? So as a clinician, you may ask yourself, is food access been inconsistent? Is there body dissatisfaction? What are we seeing on the growth chart? How much distress is this child and family experiencing? And do these behaviors change, or are they improving as food stability improves? And how is this child's mental health? As practitioners, curiosity should come before conclusion. This would be a good child to do screenings on. Pairing the food insecurity screening with mental health screening, looking at growth monitoring, and potentially an eating disorder screening tool can help aid in assessment.
So next,
That's okay. That's okay. So high rates of trauma exist in those with eating disorders. So we're going to briefly discuss a trauma-informed approach to care. Trauma is any disturbing experience that results in significant fear, helplessness, dissociation, confusion, or other disruptive feelings intense enough to have a long-lasting negative effect on a person's attitudes, behavior, and other aspects of functioning. Traumatic events include those caused by human behavior, such as sexual or physical assault, war, industrial accidents, physical injury, as well as by nature, such as earthquakes or tornadoes, and often challenge an individual's view of the world as being safe and predictable. Coexisting trauma complicates eating disorder, illness, and treatment. An umbrella review of 199 publications was conducted in 2025, finding higher rates of trauma in patients with eating disorders compared to healthy controls, specifically binge purge type rather than restrictive presentations. Trauma-informed care is a strengths-based framework that is grounded in understanding and responsiveness to the impact of trauma. It emphasizes physical, psychological, and emotional safety for providers and survivors and creates opportunities for survivors to build a sense of control and empowerment. The trauma-informed care emphasizes safety, trust and transparency, empowerment, collaboration, and cultural humility.
So we know that food insecurity is can be associated with trauma. It could be trauma in its of itself for children. One study in Canada showed that those children who experienced food insecurity had more risk of mood disorders, anxiety, low life satisfaction. And we have articles that show that food trauma includes psychological harm and emotional distress, which stem from the inadequate and inconsistent availability of food. There's a study that shows that 1 in 7 or kids who experience 3 ACEs or adverse childhood experiences are likely to be 1 in 7 having food insecurity versus those who have 3 that don't experience food insecurity is much lower risk for trauma. So food insecurity itself can function as chronic trauma.
Unbiased and compassionate care is especially important for clients experiencing food insecurity, given potential high levels of shame, which increases vulnerability to eating disorders. Trauma-informed care shifts the lens from what is wrong to what has happened. We want to try to create safety in discussing these challenges for our patients. A goal is to foster felt safety and partnership while respecting cultural food practices and family autonomy, and partnering with our patients and families and caregivers to improve engagement. When speaking with caregivers, we want to separate access issues from parenting quality. Compassionate responses express care, non-judgment, and validation of the individual's specific challenges. For example, instead of asking, "Why is your child overeating?" consider, "Many families experience changes in eating patterns when food access is unpredictable. What does this look like for you?" This phrasing normalizes the experience, reduces blame, and invites context. Validating coping strategies before offering suggestions for change can increase trust and cooperation. We want to avoid moralizing food choices by labeling foods as good and bad, and small shifts in our language can significantly reduce shame. When we're discussing growth or nutrition, we want to emphasize shared goals of being best interests for our patients and families. We want to ask permission before suggesting referrals and recognize that caregivers may carry deep shame about their food access. So we might say, "I want to make sure that we're supporting both growth and your family's needs. Would it be okay if we talked about some available resources today?" So now we're going to talk a little bit about collaborative care, because addressing food insecurity and eating behaviors requires interdisciplinary collaboration. Open-ended questions are needed in addition to screening instruments. Eating disorder assessments were not developed with food insecurity considerations in mind. So we recognize that primary care appointments do not often allow a lot of time to engage in in-depth discussion surrounding food choices and what influences them. If screening tools are not currently a standard, or further nutrition assessment is needed based on screening results, or nutrition counseling and education is required, primary care providers can provide referrals to registered dietitians for follow-up. When nutrition, growth, or feeding concerns are identified, registered dietitians can also be valuable resources to primary care providers. During appointments with registered dietitians, we'll discuss eating patterns, preferences, food access, further assess nutrition status, changes in nutritional intake that are leading to weight changes or growth faltering, as well as investigate how food insecurity could be influencing the individual's eating behavior, weight, and exercise routine. Once obtaining this information, providers can provide individualized recommendations to increase nutrition based on the root cause and influences. When eating disorder symptoms are detected, individuals should be referred to eating disorder specific mental health care that can be provided simultaneously with nutrition therapy. Comprehensive treatment teams for addressing eating disorders include therapists, dietitian, physician, and psychiatrists, as well as community resources if needed. Knowing about community resources such as food banks, pantries, and soup kitchens is also important for families with food insecurity. We encourage practitioners to be cautious about recommending weight loss to children and adolescents, particularly in the context of food insecurity. If individuals feel pressure to lose weight, particularly from health professionals, but have limited access and autonomy surrounding food, they may resort to extreme measures such as extreme dietary restriction to manage weight. Because dietary restriction increases the risk for binge eating, it's unlikely to yield weight loss if that occurs. Discussing with patients and families the harms of using extreme weight control methods and encouraging health-related behavior engagement rather than focusing on weight outcomes can be supportive for these individuals. Having a weight neutral approach with more of a focus on actionable health behaviors and subsequent outcomes can encourage clients to prioritize their health while maintaining a positive relationship with food and their bodies. For example, encouraging clients to eat as consistently as possible to reduce binge eating vulnerability while also recognizing that this may be a challenge with individuals experiencing food insecurity. Multiple large-scale randomized clinical trials indicate that decreases in disease incidence can occur with improved diet quality and physical activity among individuals of all sizes, whether or not weight change occurs in the process. This suggests that compassionate encouragement of health behaviors without an emphasis on weight is likely to enhance health without triggering eating disorder patterns. And regular visits with registered dietitians can help support these behavior changes. Communication and shared documentation between providers can increase follow-through and improve coordination. And when you're able to introduce a social worker or a registered dietitian during an office visit, that's often more effective than handing out a phone number. And scheduling follow-ups at that time can also help monitor problems before they escalate. Small system changes such as routine screening, a referral protocol, or a list of local resources can meaningfully improve outcomes. As pediatric providers, we have an opportunity to approach eating behaviors with curiosity rather than assumption and compassion rather than correction. When we understand the context, we will provide better care for our patients.
So just some quick resources: WIC, SNAP, school meal programs, weekend food programs are options, food pantries and soup kitchens, just considering if the family is able to make it to that food pantry. So how do you find those food pantries? Using this findhelp.org is a great website to find food pantries and other supports near the family. So in conclusion, we're going to have the review of the key messages. So food insecurity and disordered eating can be related. We need to be mindful that adaptive survival behaviors in food insecure households may be similar to those of disordered eating behaviors. So we need to tease those out. Using a trauma-informed approach is important for both eating disorder and food insecurity. And collaboration is very vital in improving both of these instances in family households. So here is our further resources that you can check out, and we welcome any questions.
Thank you so much for your presentation. This is fantastic. I know there are a lot of links, so we will be sharing the slides so you can access these resources. I popped just a couple in the chat as we were looking through things today. Any questions? I don't have any in the chat yet, so if anyone wants to come off mute to ask or pop in the chat, you can do so now. Okay, if anyone does have a question that comes up later, I included Sue Javi's email in the chat, and she will also be sending the follow-up link to claim CME or MOC Part 2 credit. So you'll have her email to respond if you do think of something later and want to ask. We can pass it on to the team. Okay. So on this slide, you can see here there are details about our outcome page and a link or a QR code you can scan, but we will email the link as well to claim your CME credit. And those certificates will be sent within 10 days of completing the survey. And then on the next slide is again Sue Hobby's contact information, and you'll be receiving the slides and other follow-up from her. And then I think we might have one more slide.
Oh, just references, which is
Okay, perfect.
yeah.
Several slides of references, which are great. You'll have these to click on any links and check everything out. And then kind of a final reminder, you can download the Parenting at Mealtime and Playtime app if you have not yet. It's available on the Apple Store or in Google Play. And that is everything for today. So I just want to thank you, Erin and Danielle, for all of the great information and all of our attendees for joining today. We will close our training, and again, you'll receive some follow-up information via email. Have a great rest of your day, everyone.
Thank
Thank
you.
you.